This is Dr. Raj Chandwaney, and I'm presenting a case of an in-stent circumflex chronic total occlusion that was solved via HDR facilitated antegrade wiring. This is a case of a 62-year-old woman who's referred to me for circumflex CTO PCI by another colleague in my practice. The patient recently presented to him for a second opinion. She reported suffering with chronic angina for more than 10 years. She has long-standing exertional symptoms that severely worsened during the recent months. She now also experiences episodes walking across a room and sometimes even at rest. Her workup led to a cardiac catheterization that reveals patent left anterior descending coronary artery and right coronary artery stents, as well as an in-stent circumflex chronic total occlusion that was originally documented back in 2014 at another facility in my community. CTO PCI was attempted in 2014 by another operator, but unsuccessful. Since then, she's been treated medically. Her echo reveals normal left ventricular systolic function, and there's no significant valve disease. She's on good anti-anginal therapies. Her past medical history includes coronary artery disease with stent placements in 2001 and 2008. Again, her prior cardiac catheterization procedures in 2014 and 2020 documented patent stents in the left anterior descending coronary artery and right coronary artery, but a circumflex chronic total occlusion within a previously placed stent. She had that unsuccessful CTO PCI attempt in 2014 by another operator in my community. Otherwise, she has standard risk factors. Her physical exam is remarkable for the fact that her anti-anginals are optimized based on good heart rate and blood pressure control. Her EKG shows no Q waves. Here's an angiogram of the left coronary artery, which shows the left circumflex coronary artery chronic total occlusion within a previously placed stent. And the chronic total occlusion is approximately 30 to 35 millimeters long. This is a dual guide catheter angiogram, which provides additional anatomic information regarding the chronic total occlusion. So we started with a Mongo intracoronary guide wire that was inside of a Mamba Flex microcatheter that was inside of a 7 French trap liner that was inside of a 7 French EBU 3.5 guide catheter. The proximal cap of the chronic total occlusion was initially probed using the Mongo intracoronary guide wire, but not easily passed. Therefore, we advanced our Mamba Flex microcatheter into the proximal cap of the chronic total occlusion and administered approximately 0.5 milliliter of contrast directly into the proximal cap. Angiography shows that the contrast is entering the branch vessels, but not traveling through the entire length of the chronic total occlusion. As initially described by Dr. Carlino and his colleagues, this would be considered a type 2B contrast pattern seen with HDR, in that the contrast is only entering the branch vessel but not going all the way down through the entire length of the chronic total occlusion. Despite this, after performing HDR, we were able to easily advance our Mongo intracoronary guide wire through the entire length of the chronic total occlusion into the distal segment of the vessel. Angiography confirmed that our wire was in the true lumen of the wire distally. We then performed intravascular ultrasound-guided angioplasty and drug-eluting stent placements, and an excellent angiographic result was achieved. In conclusion, early application of HDR will sometimes facilitate efficient crossing of in-stent chronic total occlusions via antegrade wiring using polymer jacketed wires. Thank you for your interest in this case.